What's the absolute most dangerous tool you can bring into an older adult's room? Think about it for a second. Hint, it's not a misplaced needle and it's not a faulty IV pump. It's actually our words. It's how we speak. Hey everyone, I'm so glad you're here. Today, we're looking at how our communication, backed by our clinical knowledge, can literally either cause harm or create profound healing.
So welcome to This Explainer, the cell-to-soul review for gerontological nursing. We're going to take all that abstract science you've been learning and connect it directly to your everyday patient interactions. Because once you truly understand cellular biology and psychology, it completely changes how you talk to, engage with, and assess your older patients.
All right, let's look at our roadmap for today. We are going to cover biological theories of aging, psychosocial identity, why we desperately need to erase elder speak, practical therapeutic communication, and finally, holistic clinical assessment. Let's jump right in.
Section 1. Biological Theories of Aging, Visualizing the Microscopic. Okay, to really grasp aging, we have to zoom way in, down to the cellular level. Check out these two terms, ROS, which stands for reactive oxygen species, and inflamma-aging. So ROS are these unstable molecules inside our cells. A little bit is fine, but when they accumulate, they cause oxidative stress and cellular damage. Your body reacts to that stress with a constant low-level immune response. And that slow burn, that's what we call inflamma-aging. It's a foundational theory of biological aging. And you can see exactly why it matters right here. Look at how inflammaging is right in the middle of this web, connecting to almost every major chronic condition you're going to see on the floor. Alzheimer's, type 2 diabetes, osteoporosis, it's all linked. This is exactly why our older patients don't just have one single issue. They have complex, overlapping conditions. It really highlights why they require our absolute utmost patience and clinical understanding.
Now here's something super fascinating about how our actual DNA ages. See those little green caps at the ends of the chromosomes? Those are telomeres. You can think of them literally like the protective plastic tips at the ends of your shoelaces. Every single time a cell divides, moving from left to right here, those telomeres get a little bit shorter. By the time someone reaches their 80s, they can become so short that the cell just stops dividing altogether, and that leads to genetic errors and what we call senescence.
So knowing that our cells are under this kind of microscopic stress, what can we actually do? Well, here are 6 practical keys to healthy aging that you can discuss with your patients to help reduce that cellular damage. We want to encourage a balanced diet, cutting back on sugar, getting regular exercise, managing stress, keeping them unchallenged, and sticking to regular checkups. Basically, we're taking all that complex biology and translating it into simple, everyday lifestyle choices that really make a difference.
Section 2. Psychosocial Aging and Identity.
All right, let's shift gears from the physical body to the mind. Read this scenario with me, and I want you to picture the real person behind the textbook. A 75-year-old patient has remained unmarried and childless. She shares with you that she feels her life has little meaning and no one cares if she lives or dies. Wow. Just listen to the profound isolation there. Guys, this isn't just a clinical presentation to chart. This is a human crisis happening right in front of you.
So, putting your clinical judgment hats on, let's do a quick NCLEX style check. Based on what she just said, what is the primary issue this patient needs to resolve? Is it A, premature disengagement, B, ego integrity versus despair, C, inability to provide continuity, or D, over-involvement in gerotranscendence? Take a second, trust your gut, and lock in your answer.
If you went with B, you hit the nail right on the head. This is Erikson's developmental task of ego integrity versus despair. When people reach late adulthood, they're doing this massive mental heavy lifting. They're trying to come to terms with their life, feeling whole, and processing past triumphs and, past disappointments. When you recognize that despair in a patient, you realize that your therapeutic communication isn't just being nice. It is a vital, active intervention for someone struggling to find meaning.
Which brings us to Section 3, Erasing Elder Speak.
This is absolutely crucial, folks. We have got to understand the stark difference between the left and right side of this screen. On the left, we have elder speak. You know what this is. It's using that high-pitched sing-song voice, calling an 85-year-old man sweetie or honey, using baby talk, or overly simple sentences. Listen to me. This is a form of ageism, plain and simple. And a lot of times, nurses don't even realize they're doing it. We need to completely replace that with therapeutic engagement, over on the right. That means active listening, immense patience, clarifying what they mean, and treating them like the adults they are by using respectful adult vocabulary. That is how you empower your patients.
Section 4. Therapeutic Communication Strategies.
Let's try another critical thinking question to really highlight how clinical communication is a specific skill, totally different from everyday chatting. Let's say you're caring for an 80-year-old patient and you want to use reminiscence as therapy. Which of these questions is the best way to encourage that? Asking about their favorite food, how many kids they have, if religion brings them comfort, or asking about their favorite childhood memories?
The absolute best approach here is asking, what are some of your favorite childhood memories? See, reminiscing isn't just shooting the breeze to pass the time on a slow shift. It's actually one of the most important psychological tasks for older adults. It provides amazing cognitive stimulation, it boosts socialization, and most importantly, it helps them actively construct their life story, which, if you remember Erickson's stages, directly fights off that despair we were just talking about.
To truly connect with our patients, we have to look at the whole picture using holistic care. Notice how this encompasses physical, social, psychological, and spiritual needs. Look, I know on a busy med-surg unit it is so easy to get tunnel vision and only focus on the physical stuff, but we have to use open-ended questions to assess those spiritual needs too. Finding peace and spiritual comfort often becomes drastically more important as people get older, and we cannot ignore that part of their care.
Section 5. Holistic Clinical Assessment. So how do we put all this into practice? Here are some key assessment factors you'll use constantly. You've got your FAN-CAPES approach, your comprehensive review of systems, and of course, checking cognitive ability using standardized tools like the Mini Mental State Exam or the Mini COG. And remember, you always have to critically weigh what the patient tells you, their self-report, versus what a family member or caregiver is reporting. Keep in mind, a true holistic assessment starts the moment you walk in the room, picking up on physical, spiritual, and psychosocial cues way before you ever pull out your stethoscope.
Now, if you want an incredibly reliable framework to use on the floor, you are going to love the Fulmer Spices tool. It is a fantastic overall assessment method specifically for older adults. It's an acronym that systematically reminds you to check for sleep disorders, problems with eating, incontinence, confusion, evidence of falls, and skin breakdown. Just quickly walking through spices in your head ensures you catch those high-risk geriatric syndromes before they become major complications.
And finally, we have to assess how well they can actually function in their day-to-day lives. This means looking at ADLs, or activities of daily living, like eating, bathing, and getting dressed, as well as IADLs, which are those independent activities, like managing a checkbook or keeping track of medications. Using standard tools like the CATS or Barthel Index is absolutely essential here. They give you a systematic, objective measurement of a patient's independence, so you know exactly how safe they're going to be in their environment.
All right, I want to wrap up this explainer by leaving you with a really profound question to chew on before your next clinical rotation. How can living with a chronic illness improve or worsen your outlook on life? I really want you to think deeply about this. Think about the biological wear and tear we talked about, those massive psychosocial shifts, and how your words, your conscious, respectful, therapeutic engagement can literally tip the scales for your patient's well-being. Reflect on that, keep it with you, and go be the incredible, empathetic nurses I know you're all going to be.